Record. Okay. All right. Sorry, I've been talking to you without you hearing. Okay. Well, I went through. So we're talking about the diagnosis of tuberculosis in children today, and there's many things you could talk about regarding TB. We could talk about the treatment, or we could talk about the complications, or we could talk about multi-drug resistant TB. But I think we need to be really good at the diagnosis of TB. And the reason to be really good at it is so that we don't overdiagnose TB and we don't underdiagnose TB. This is very important. And I'll just let some more people in. One of the reasons why the diagnosis of TB in children is more difficult, I'm sure you know this, but TB is what we call paucibacillary in children, especially in young children, paucibacillary. It can cause severe disease, but still there often isn't a lot of bacteria, bacilli in the lungs, for example. And so pauci means few or a minimal amount. Unlike in adults where it's multibacillary, there's a heavy burden of tubercle bacilli in the lungs, and so it's much easier to find. So paucibacillary is one reason why the diagnosis of TB is more difficult in children. The other reason is because all the symptoms that we come to rely upon and all the signs are non-specific. So chronic cough could be due to TB, but it also could be due to the fact that the child's got recurrent viral infections, or the child's got asthma, or they've got bronchiectasis or chronic wet cough. There's lots of other reasons why a child might have a chronic cough, recurrent aspiration, that sort of thing. So while chronic cough, if you take it as a symptom, it could be TB, but it could also be lots of other things. And so if we diagnosed all children with chronic cough as having TB, then we'd be overdiagnosing TB. And the same is true for fever and for weight loss. If we diagnosed every child with fever and weight loss as having TB, then we'd be missing a lot of other very important diagnoses, and we'd be overdiagnosing TB. Right? The same is true for the signs of TB, like chest crackles, coarse crackles in the lungs. We often see that in children with pulmonary TB, and we often see coarse crackles and wasting. But if we diagnosed every child with coarse crackles and wasting as having TB, then we'd be overdiagnosing TB, right? In regard to tests that we have, so that's the clinical features. In regard to tests, they're often insensitive. That means that if you, for every 10 children truly with TB, then we might find that their sputum is positive in only 3 or 4. A sputum or gastric aspirate. And that's because TB is paucibacillary and we often don't find it. So the tests themselves, if you looked in sputum for acid-fast bacilli in 10 children, then you might find it positive in 3 or 4. It's about a third of the time we'll find it positive. Similarly, for chest x-ray findings, the consolidation on a chest x-ray might be due to TB, but of course it might just be due to bacterial pneumonia or some other condition. So because all the clinical signs we have and the tests we have are non-specific or insensitive, it doesn't mean they're not good. It just means we've got to put them all together. And we've got to use a process called deductive reasoning. And deductive reasoning is where we prioritize the differential diagnosis, and that might include TB, and we order the likelihood of the diagnosis, the TB with other diagnoses, and we exclude other common conditions or other conditions by clinical features, history examination, and special tests. And then we come upon the most likely diagnosis. That's deductive reasoning. And so we just arrive at a diagnosis based on a process of deductive reasoning. And that just means putting all the information we have together, right? With TB, it's often very difficult to confirm TB in many cases, isn't it? But it's okay to make a clinical diagnosis of probable TB if we've gone through a process of making a careful clinical assessment, doing the tests we have, understanding the precision of the tests we have, and then making some diagnosis based on deductive reasoning. So we often come to a diagnosis, this is probably TB. Of course, if we find that the sputum's positive, then that's not just probable TB, that's confirmed TB. But nonetheless, we can make diagnoses of probable TB just as well, I think. And I suppose I've just talked about this really, but the idea is to integrate the history, the examination, the radiology we have, and that might be a plain X-ray or a CT scan or an ultrasound scan. Ultrasound can help us with the diagnosis of some types of TB. And then we have tests, and two types of tests really. Tests that tell us something about the presence of the Mycobacterium tuberculosis. And then some tests that we have that tell us something about the immune response to Mycobacterium tuberculosis. So we do Ziehl Neelsen stains, of course, and that looks for acid-fast bacilli. So that's the bacteria truly there. We culture certain specimens, and that takes a long time, of course, but that can tell you that the bacteria are actually there. And then we can look at histopathology in some specimens, and that will tell you that the bacteria are actually there, or they might find pathology consistent with TB, such as caseating granulomas. And then we can look at PCR, like a GeneXpert test, and that will tell us that the DNA of the bacteria is actually there. The bacteria may or may not be alive, but the DNA is there. And then there's some other tests that tell us something about the immunology, like an immune response to TB. And that's like the tuberculin skin test, or there's other tests like called the quantiferon gold test. Don't worry about that one, but the tuberculin skin test or a Mantoux test is an immune response to TB. And then you need to think about the types of specimens that you can take for children who've got TB. It might be sputum in older children, or gastric aspirate, or pleural fluid, or a fine needle aspirate of a lymph node, or CSF, or acidic fluid. And so there's lots of different tests we can do on lots of different sorts of specimens. And I think as pediatricians, we need to be really good. We need to be experts at, in this particular child, what combination of history and examination and imaging and tests for TB and immunological tests for TB should we do, right? And sometimes we start with just the basic things, and we either find the diagnosis or we're still struggling with the diagnosis, so we look to other tests. And that's okay too. You don't have to order everything at once. You can use a process of deductive reasoning where you do the basics first and then go on to additional tests if you need to. And I think that's what we should do. We shouldn't do all the tests at once, because then you'll be doing unnecessary tests. You should do the basics first and then more advanced tests. On the history and the examination, I guess for those who are sort of new to pediatrics or those who are starting out, we really need to get good at understanding what the historical features are that suggest TB. And we do this a lot, don't we? We want to know the duration of symptoms. When we're asking about the duration of symptoms, we need to be very careful, I think, about understanding whether or not a child truly has a chronic cough or whether they've got an intermittent cough. So some children come with, the parents might say they've had a cough for 3 months, but in fact, they've just had a cough for a week, and then they've had 2 weeks where they didn't have cough, and then they had a cough for another week, and then another period without cough. That's not really like TB. And whereas with TB, the child will be coughing every day or almost every day, and that will be associated with fevers or weight loss during that time. If they've only had a cough for a week, they might not have weight loss, but if they've had a cough for a month, then they should have weight loss typically, and they should have fevers. And so it's pretty understanding the things that are more specific for TB that we should ask for. Right? If a child has TB, not only will they have respiratory signs, but typically their activity's reduced, they'll have fatigue, or they'll have reduced playfulness, they'd be more lethargic. We need to ask a really good nutritional history, and we need to document weight loss, or whether the child's failing to thrive, their immunization history, and of course their social history, including TB contact. And we should be very specific about what the highest risk TB contacts are. So the risk to an infant whose mother has TB is extremely high in the first year of life. the risk is highest if a child under the age of 3 has contact with TB, an adult with TB, untreated TB, then their risk is very high in the next year of life. In terms of signs, we should look for, again, it's putting everything together. We should look for signs that suggest chronic respiratory problems. So that's different to the child who comes along with fast breathing and chest indrawing and they've only had it for a few days. So looking for signs of chest deformity, coarse crackles suggest something that's more chronic. If we see a large pleural effusion in a child who doesn't look very unwell, that's suggestive of TB. If we hear wheezes with unilateral airway obstruction, that's suggestive of TB too, isn't it? Because of lymph node obstruction. So there are some, while many signs are non-specific for TB, there are some signs that are a bit more specific for TB, and we need to know what they are. We need to do a growth and nutritional assessment and then look for signs of extra-pulmonary TB, so lymphadenopathy, ascites, hepatosplenomegaly, kyphoscoliosis, lordosis. Now, each of these signs could be present in children who've got other diseases. Hepatosplenomegaly might suggest a leukemia, or ascites might suggest liver disease, but it's really putting everything together, the epidemiological risk with the history and the examination and the clinical features that will get good at diagnosing TB. We should also note other comorbidities. So because children with TB will have either a good prognosis or a poor prognosis depending on the extent of TB and depending on the extent of other comorbidities. So anemia or HIV, it's also important to diagnose. So when you're focused on doing the history and the examination of a child who might have TB, then you need to be thinking about all of these things. Right. We've got the TB score, and this is very important because all those history and examination features that I mentioned to you before, they're all included in the TB score. And if you do a TB score in a child, then if the score, as you know, if the score is more than 7, then it's more likely that the child has TB than they do have other diseases. That doesn't mean they can't have other diseases. There are many, many other diseases that will give you a TB score more than 7. And that's why the TB score is very good in places where other investigations are less available. But where you've got other investigations to use, then using history, examination, the TB score, and those other investigations is also useful. All of these history and examination features I mentioned before are included in the TB score. And yeah, the TB score is a good screening test. And I think that for most children in most places who are likely to have TB, then you should do the TB score as part of the history and the examination. But you should also think about whether or not there's anything else that might be causing those symptoms. And so, for example, a child with a TB score of more than 7 might have HIV, or they might have bronchiectasis. They might have some form of cancer like a lymphoma, or some other chronic infection like chronic osteomyelitis or something else. So the main thing is to not every child with a TB score more than 7 has TB, but we need to be then using the process of deductive reasoning to try to work out, could there be anything else causing this child's TB, this child's symptoms. So I've said it several times now, but the way we diagnose TB is to integrate the history and the examination and the TB score with other diagnostic tests and consider and exclude other conditions. That's what we should do. Okay, I wanted to, we all know about the Ziehl Neelsen test and we know about the GeneXpert test, but I wanted to, I think we need to be experts in these types of tests. They're common tests, and because we order them, we should know how they're done. And I think it's quite interesting how the Ziehl Neelsen test is actually, how it identifies acid-fast bacilli. These are the acid-fast bacilli, aren't they? The pink staining bacilli. You can see there the little, they look like chains of bacteria, but they're bacilli. And the reason why they're acid fast is because they've got a thick waxy cell wall. Mycobacterium tuberculosis has a thick waxy cell wall, a bit different to other bacteria that aren't acid fast. And the thick waxy cell wall is made of a compound called mycolic acid, and that makes the bacteria very hardy. It survives on dry surfaces for very prolonged periods of time, the TB bacteria, and it's because of the mycolic acid cell wall. And when you, to do a Ziehl Neelsen stain, those of you who've done it will know, but you stain the sputum smear. First of all, you heat the smear, and then you stain it with carbofuscin. And carbofuscin is a red stain, and that will stain everything red. You then wash the stain with water and then 3% acid alcohol, and then the stain, instead of being bright red, becomes pale pink. And then you wash the whole stain again with methylene blue, and then you dry it. And when you the mycobacterium will retain the carbofuscin stain, and it will stay red, and it won't be washed off with the acid alcohol. So when we're washing off the acid alcohol, you're washing it off all the any other bacteria that might be there, any of the pus cells or other inflammatory cells that might be there, that might have taken up some of the red dye as well, because they don't have mycolic acid. It's the mycolic acid that retains the red dye. And so that's why all you see in a AFB stain is acid-fast bacilli, and other things look a bit blue because of the methylene blue. Pus cells, for example, leukocytes, you can see in this stain. So that's the Ziehl Neelsen stain for acid-fast bacilli. I think it's important that we know something about the GeneXpert test. And I think most of you know about that these days, but that's a nucleic acid amplification test. We used to call it PCR. It's the same thing, a polymerase chain reaction test. And these days we have these PCR machines that do the GeneXpert test. It used to be a much longer process, but with GeneXpert machines, they're good at identifying the DNA from Mycobacterium tuberculosis. All it does is it's a process by which all the TB bacteria are concentrated from a sputum sample, and then it extracts the genetic material, the genomic material from the nucleus of the bacteria, and then amplifies the genomic material by PCR, which just means this thing called polymerase chain reaction just multiplies the DNA thousands or tens of thousands of times. And by doing that, instead of just looking at one strand of DNA, it's looking at thousands and thousands of strands of DNA. And that's why it can detect Mycobacterium tuberculosis, the RPOB gene. That's the gene that the GeneXpert test detects. And it also detects the genes for resistance to rifampicin. It doesn't tell you whether the child or the isolate is multi-drug resistant. It'll only tell you whether it's rifampicin resistant. But from that, you can think about whether or not the patient's got MDR TB or not. But it will detect whether Mycobacterium is present and whether or not there's resistance to rifampicin. That's the main thing to remember. The GeneXpert test, like I said earlier, the GeneXpert test, as I said earlier, it detects whether or not Mycobacterium is present, but it doesn't tell you whether the bacteria are alive or dead. All right, and so if you do for the Ziehl Neelsen test, it really only detects live bacteria because there won't be much mycolic acid left after a bacteria dies. Whereas when mycobacteria die, there can still be a lot of DNA around, which can be amplified. And so the reason why I say this is because if you're treating a patient, their GeneXpert test may remain positive even after they're effectively treated. So to know whether a patient is smear negative, you don't use the GeneXpert test. It's a good way to diagnose TB, but to follow whether or not the patient has been treated or not, well, effectively or not. Usually we don't rely on the GeneXpert test to tell us that. We'll look for sputum to see if they're still smear positive or culture positive, and we see what their clinical response to treatment is. In children, the GeneXpert test is a bit less sensitive than it is in adults, and that just relates to the porcibacillary nature of TB. It's not anything specific about the test in children, it's just that adults are multibacillary and children are porcibacillary. I'm sorry, Glenson, what's that? Glenson, could you mute your microphone, please? Thank you. Okay, I'll keep going. There's a new test out that it's useful to know about because I think it'll be available, or it is available in some countries now, but it'll be available in PNG in the next year. In fact, there is some of the Xpert Ultra available now. It's the Xpert Ultra is like GeneXpert, and it's a next generation GeneXpert Mycobacterium PCR test, and it also detects rifampicin resistance. And the benefit of it is that it's more sensitive than the GeneXpert test. So it's just a better test than GeneXpert, the Xpert Ultra, and it's been used also like GeneXpert on lymph nodes, on if you take a fine needle aspirate of lymph nodes, or in TB meningitis, like GeneXpert can be used on CSF. The main thing is to know is that Xpert Ultra is coming, and it's just a new next generation PCR test for TB, and it'll be a little bit better. But it's all the PCR tests will only diagnose TB in about 1/3 of cases, we know. I wanted to talk a bit about the X-ray features of TB. We've looked at a number of X-rays this year on TB, but just to I've drawn on this small picture just all the different signs that you can see on an X-ray and what the pathology is. And so the first sign we often see is a gone focus, which is the primary. It's an inflammatory response to primary TB, and sometimes that will be just in the peri-hilar region, typically speaking. That's the first sign. So it's just around opacification usually. Other signs, of course, can include consolidation, or sometimes we see airway compression from lymph nodes, and that can lead to hyperinflation of one lung. Or sometimes we'll see miliary nodules, or sometimes we'll see a large pleural effusion. So sometimes on ultrasound of the abdomen, you'll see lymph nodes, which are hypoechoic, which means they're black they're black circles on ultrasound. I'll show you some pictures of those. So there's lots of different things we can see on plain chest X-rays and on ultrasound, and of course on CT scans as well. But I think we should be experts in looking at plain chest X-rays and assessing whether or not the features are more like TB or more like some other condition. So on chest X-ray, we can see consolidation, like either segmental or lobar consolidation. About half the cases, that's all we see. And sometimes we see bronchopneumonic consolidation, that is extensive bronchopneumonia, about 1/3 of the cases. Also about 1/3 you may see hilar or mediastinal lymphadenopathy. Cavities in the lung, usually in older children, not so much in younger children. And about 13% of cases have miliary opacification. I'll show you some pictures. And then about 11% have pleural effusions. This was a very large study of multi-drug resistant TB, and looking at the radiographic manifestations, it's a little more severe X-ray changes with MDR TB than with just standard TB, but all these features can be found with drug-sensitive TB as well. This is I mentioned the gone focus before. This is a primary gone focus, which just reflects, it's a sign of primary TB. There's no other consolidation you can see, but there's a round opacity. And the question is, what else could this be? Well, it could be something else. It could be a lymph node, a very large lymph node, for example. It could be a what we call a round pneumonia. All right, round pneumonia, which is just a bacterial pneumonia that is given a round appearance on the X-ray. So not everything that looks like this will be a gone focus, and that's why you need to integrate the history and the examination with the radiographic findings and the epidemiological risk, that is the risk. Sometimes you'll see the gone focus will have calcified, and you can see here, this is a calcified gone focus and lymph nodes. The perihilar lymph nodes are all calcified. Can you see how white this area is? This is far more white than what you'd normally see with consolidation or collapse, isn't it? Really bright whiteness, looks like bright whiteness on the X-ray is calcification, and you've got to think that that's probably calcified lymph nodes, and therefore it may be TB. Sometimes this looks a bit like a gone focus, but in fact it's actually large perihilar lymph nodes. All right, and so sometimes we look at this and we say there's perihilar consolidation, but you can see that the appearance is very round. And if you see a roundness around the perihilar region, like circular opacified lesions, then they could be, that's TB, or it's lymphoma, a Hodgkin's disease. The last child I saw that we thought had TB actually had Hodgkin's disease, looked just like this. Sometimes enlargement of the pulmonary arteries, if a child's got pulmonary hypertension, that can look very similar to that. And the only clue between the difference between this and this is that what you often see in some types of pulmonary hypertension, you can see the extensive vascular markings extending from the lungs. I think sometimes it's quite difficult to tell, though, the difference between perihilar lymph nodes and enlarged prominent pulmonary arteries. This child had large pulmonary arteries, it didn't have TB, whereas this child had large perihilar lymph nodes and did have TB. So they can be a little hard to make a distinction between the two. Again, the history and the examination can be a bit more revealing. This is obviously a Miliary pattern in the chest X-ray, and you can there's many different I guess manifestations of a Miliary pattern. It can be very light, it can be a bit more coarse, it can be quite opaque like the one on the left, or very, very diffuse. But there's not many other conditions that this could be. So this is highly specific for TB. If you see a child who's got this type of X-ray, these were two children who had TB, that you wouldn't have otherwise known. You wouldn't have known that they definitely had TB until you see the X-ray and you can say, well, they've definitely got TB. This is a young adolescent girl also, and this is a more fainter Miliary pattern. You can see this was a young girl who had CNS TB, but also pulmonary TB, and she presented with seizures and a depressed conscious state, and had some signs of TB on her CT scan of her head, and she didn't have much in the way of respiratory signs. But when you look at her chest X-ray, you can see that she's got a diffuse, very fine Miliary pattern on her chest X-ray as well. This, I think, is an interesting case of a small infant. So Miliary TB can occur in young infants, but it can also, in older children, of course, but it can also occur in young infants. And this was a child who was only a few months of age. And what I think is interesting about this appearance is that back on the 6th of October, this was some years ago now, but on the 6th of October, you wouldn't have picked this as being Miliary TB, and you might have said, well, there's a bit of consolidation in the upper lobes there. It could be anything, couldn't it? It could be a viral pneumonia or a bacterial pneumonia. And then this is somewhere between 3 and 4 weeks later, the child has extensive Miliary TB, Miliary pattern on the chest X-ray. And so untreated, this is how quick Miliary TB can progress. And I think it's an interesting often we don't see the change because we only see the X-ray at a time when a child's very sick. But just to see the rapid progression of miliary TB, I think is important. I wanted to talk a bit about the Mantoux test, because the Mantoux test is an important test. We've often not done Mantoux tests, and the reason has been several-fold. One is that the tuberculin, the purified protein derivatives, is often not been available. In fact, it hasn't been available for a long time. And also because we say, well, when I'll just let someone in, but when we're in a TB endemic area, then everybody will have a positive Mantoux. And it's sort of true that a Mantoux test is not specific. That is, many people who don't have TB disease will have a positive Mantoux. But you can, Angela, do you mind muting your microphone? Thank you. But if yes, so a Mantoux test doesn't tell you the difference between TB infection and TB disease. TB infection is just someone at some stage, many of us at some stage during our lives will have been exposed to TB and got an infection with TB, and we might not have TB disease. We just have maybe a primary focus of TB that's remaining dormant. But the people who've had that will still have a positive Mantoux. But I think it's, when we interpret a Mantoux test, we have to do it properly, and we have to interpret the size of the induration. And so this, the one on the left is an induration that was relatively small in a patient who had either TB infection but not disease, and who had been exposed. It also had BCG vaccine. So if the Mantoux reaction is 5 millimeters or less, then probably it just reflects TB infection or the patient having a Mantoux test. But if it's a larger induration, more than 10 millimeters, then it's highly likely to be TB. And the larger it is, and the larger the induration, the more likely it is that the person's got TB. And so if you see 15 or 20 millimeters of induration, then you've got to think that the person probably has TB disease. So I'm not saying the Mantoux test is perfect, but if we interpret it in an intelligent way, I feel like it's a useful adjunctive test. You can't rely on it, but it's a useful adjunctive test. But when we interpret a Mantoux test, it's important to know what it actually means. And the Mantoux, the purified protein derivative, is an extract of the tubercle bacillus. It's mixed in a glycerine, so it's called a glycerol extract of the tubercle bacillus, and we just inject it intradermally, as you know, and it mounts a delayed type hypersensitivity response. So you'll get you know what a anaphylactic response is, which is an IgE mediated hypersensitivity. It's a immediate hypersensitivity response. That's why in a person who has anaphylaxis, they get a reaction immediately. But this delayed type hypersensitivity response takes a day or two. And that's why we read the Mantoux test after 48 and 72 hours, because it's a T cell memory response. If we've been infected with TB, we have T memory cells that can respond to the injection of the PPD under the skin, the extract of tubercle bacillus under the skin. So in a TB endemic country, more than 10 millimeters of induration is positive if the patient has clinical features of TB, that is, a history consistent, examination consistent, chest X-ray consistent with TB, etc. As I said, you can't interpret a Mantoux test alone because it doesn't differentiate between active TB, like the person with TB disease, and latent TB. Latent TB being just TB infection that has become dormant, of course. And some other mycobacterial infections like leprosy, and a condition called May's complex, Mycobacterium avium intracellulare, that those conditions also will have a positive Mantoux test. So when we're thinking about the patient with the positive Mantoux test, you need to think about the possibility of other infections as well. The important thing about, if we're going to do Mantoux test, we need to know what will give you a false positive test and what will give you a false negative test. All right. And so if you've had a BCG vaccine, then you'll have a false positive test, but it'll always be less than 5 millimeters. If you've had 2 BCG vaccines, you might have a bigger Mantoux test, but it generally won't be more than 10 millimeters. So it's still a matter of interpreting the Mantoux induration in the light of the history and the examination. Also, if a person's had the Mantoux test and it becomes itchy and they scratch it, then sometimes that will cause an irritation and make the Mantoux reaction look bigger than what it is. And so that can lead to a false positive test. But very importantly, we need to understand what a false negative test is. That is, a false negative test is where the child actually has TB, but the test is negative, right? And that occurs when to go back to the first principles, if you've got a T cell immune deficiency, right, then you won't have memory T cells to mount a response. And so if a person's malnourished, then their T cell immune function is depressed. And so they're not going to mount such a strong response. So therefore they won't have such a big Mantoux reaction. If they've just had recent TB infection, like only in the last 8 or 10 weeks, then often they won't have the memory cells, because the T memory cells take some time to develop. And so often the patient who has active TB doesn't have the T memory cells to mount a response. So they may not have a positive response. If they've had glandular fever, then that can suppress your T memory cells as well, and can lead to a false negative test. For some people, a live vaccine within the last few weeks, like measles or polio vaccine, that can lead to after you've had that sort of vaccine, you mount a strong immune response, but sometimes the reaction to the Mantoux test in that period of time where the body's mounting an immune response to some other vaccine can be a bit more depressed to the Mantoux. If a child's on prednisolone or corticosteroid therapy, often they'll have a negative Mantoux test. And of course, if a patient has HIV with low CD4 counts, their T cells, and so their T cell immune response, their T helper response, their memory T cell response may be depressed, and so they may have a low response as well for their Mantoux. So just important that we know what causes a false positive test of the Mantoux, not many things, and the conditions that cause a false negative test as well. Okay. I wanted to touch on some other aspects of extra-pulmonary TB, because we often focus on pulmonary TB, but many of the children we see have different types of extra-pulmonary TB, and we need to get good at trying to investigate those types of conditions as well. Like TB can affect the kidneys, and so for children that have got multi-system TB, we should look in their urine to see if they've got what we call sterile pyuria. They might have a high white cell count, but you don't grow any bacteria in their urine, and you wonder why. And sometimes that'll be because of TB. Obviously, if they've got back pain or scoliosis, or they've got then we should, or lordosis, we should look for Pott's disease on plain X-rays. TB can sometimes affect the kidneys, and it can sometimes affect the adrenal glands, and sometimes children with a TB of the adrenal glands can present with Addison's disease. And so looking for the signs of Addison's disease in a child who might have TB can be useful. Lymph nodes in the neck, obviously matted caseating lymph nodes. Sometimes there can be a sinus draining from the neck. So there's all these different manifestations of TB. It's a truly multi-system disease, and we need to know what other investigations to do and when to suspect that these other manifestations could be TB. we'll talk a bit more about CNS TB and TB of the gastrointestinal tract as well. This is a child, this is a young adolescent boy who had what we used to call scrofula, which is just matted, caseating cervical lymph nodes. And you can see he had a sinus draining, just caseating pus from his neck. But you also might see from this that he had a white reflex. Instead of having a red reflex, he had a white reflex, and that's because he had TB of the eye, so retinal TB as well, and that can give you a white reflex. So sometimes we just need to be a bit alert to other manifestations of TB, whether it's in the kidneys or the spine or the lymph nodes or the eye or the brain, and not just focus on TB affecting the lungs. Abdominal TB we see a lot of course, don't we? And I find it useful to tap the ascites of such patients. It's usually very easy to do because usually they've got a large amount of ascites. If you are good at ultrasound, you can just ultrasound and tap where there's clearly fluid, or if you don't have ultrasound, then I just tap it out, percuss it out with my fingers, and you find the area of most dullness. In a child who's got a large amount of ascites, that can be drained for investigation. And usually these patients have an inflammatory response. It's mostly lymphocytes. If you do an ultrasound, which I know many of you can do, you should be looking for hypoechoic lymph nodes. Like I said, they're small, black, round nodules, and usually they're hypoechoic, particularly if they're caseating, and lymph nodes become hypoechoic. That means there's no echoes in the nodes, particularly if they're caseating. And sometimes you'll see other features on ultrasound, like sort of thickened multi-layered mesentery, or strands, debris within the ascites. That's quite pathognomonic. On a CT scan, we don't always do CT scans, but you'll see lots of signs like thick peritoneum. It's all layers of inflammation within the peritoneal cavity. So you see thickening of the peritoneum, the omentum, the thickened bowel wall, which you can also see on ultrasound as well. And lymph nodes on a CT scan, TB lymph nodes, look like they're hypodense, so they're black within the center, and they have a contrast enhancement around it, like a rim enhancement, a white enhancement around the lymph nodes. So there's lots of signs that are not pathognomonic for TB, but they're highly suggestive of TB if you look on ultrasound or on CT scan. I'll just show a few of these. So these are hypoechoic, that is black meaning no echoes, right? Hypoechoic large nodules that are lymph nodes within the bowel. There's another one there. And this is an ultrasound, of course. On a CT scan, you just see usually these, this is bowel, right? So here's the pelvis, the vertebral bodies, the muscles of the back, all right? These are the pelvis, the blood vessels, and the bowel. But all of this is just acidic fluid that has multiple strands of inflammation and septation, fibrous septa with some lymph nodes within it, right? And so when you see this type of thing, lots of acidic fluid with strands, lots of strands within it, then TB is the obvious condition. There can be a few other things that can give you an appearance like this, but TB is the most likely one. For central nervous system TB, so we talked about abdominal TB. For central nervous system TB, then again, I think we need to just combine history and examination. And so usually those patients have a history of meningitis or CNS symptoms that's longer than 5 days. Anything less than 5 days is much more likely to be acute bacterial meningitis or acute viral meningitis. You know that. with CNS TB, the diagnosis is difficult. In some ways, it's even more difficult, I think, than diagnosing pulmonary TB, and partly that's because sensitivity is important of any test. And when we have, for looking at CSF, the sensitivity of GeneXpert on CSF is somewhere between 28 and 79%. So the studies vary, and it depends on the amount of CSF volume that you process. And so if you've only got a small amount, like a mil of CSF or less, then it's very unlikely that you'll find TB. And it's only if you're able to take, in like an adult or an older adolescent, a larger amount of CSFs, like 8 to 10 mils, is really needed for GeneXpert testing. And that's why I think that GeneXpert has not really been found a strong place in the diagnosis of pediatric TB meningitis, because you need to take somewhere between 8 and 10 mils. If you have smaller volumes, you can still find it on GeneXpert, but not very sensitive, much less sensitive. When you've got a, the important thing about this is that if you don't find TB on GeneXpert testing of CSF, it doesn't mean the child doesn't have TB meningitis. So you can never rule it out if you don't find it. If you do find it, then that's diagnostic. But if you don't find it, then you can't rule it out. The sensitivity of Ziehl Neelsen staining on CSF is actually quite poor. I mean, it's somewhere between 10 and 20%. So again, if you don't find it, then you can't rule it out. So we fall back for CNS TB on the history, the examination, looking at the CSF and seeing that there's more lymphocytes and the protein is high. They're more sensitive indicators of TB than a Ziehl Neelsen stain or a GeneXpert test. It doesn't mean we shouldn't do those other tests, the tests for Mycobacterium tuberculosis, but it's just harder to interpret, and they're more likely to be negative. I won't go through this, but this is, if we have a child who we think might have TB, then the tests we do depend on the amount of CSF we can take. And if you've got only a small amount of CSF, then there are certain things you shouldn't do because they take up a lot of CSF. So, for example, the GeneXpert test, as I said, takes up a lot of CSF. So if you've got only a small amount of CSF, you wouldn't be doing the GeneXpert test, you'd be doing all the other tests. You know, you only need about 1/4 ml for a gram stain and about 1/2 ml for the protein and glucose, and about the same 1/4 ml for bacterial culture. So you do those tests as a matter of priority. If you had only 1 ml of CSF, then that's what you do. If you've got 3 ml of CSF, then you can do a GeneXpert test. And if you've got 4 or 5 ml of CSF, then you can do the other things. You can do Indian ink staining or cryptococcal antigen staining. And of course, you can do TB culture and Ziehl Neelsen staining. So the point is, we should decide the tests that we're going to do based on the amount of CSF we get and the probability that we'll get a result from that test, right? If you've only got a small amount, do the basics first. Do the gram stain, protein and glucose, bacterial culture, and then maybe an AFB stain because it doesn't take too much CSF. Yeah, depending on the condition, but it does depend on the amount of CSF you can get. Okay. So as I said, if you got less than 1/2 ml, then just do the basics: microscopy, gram stain, bacterial culture. The CT scan can tell us quite a lot about the likelihood of TB, and these are some children that have got TB, CNS TB, and what you can see here, I mean, you're getting better. I think you're getting used to looking at CT scans now, and this is obviously a brain CT scan, and it's an axial CT scan. These are the ventricles, so the frontal horns of the lateral ventricles, the temporal horns of the lateral ventricles. But what you can see is a diffuse blackness throughout the brain. And this is diffuse edema that you see. You could see this with a number of other conditions. You can see this, for example, with pneumococcal meningitis, where you've got extensive cerebritis. But this was a child who had MDR TB. This is another child with TB, and this is shows a enhancing lesion. You can see the enhancing lesion here with a contrast enhancement, and you can see that the ventricles are a bit larger. And so this is a child with TB with a ring enhancing lesion who has early signs of hydrocephalus. And this was that child's chest X-ray, and you can see how there's a fine miliary pattern throughout. So again, putting these two things together, this CT scan of the head could be due to a number of conditions. You could get this type of problem with a cerebral abscess or with some other CNS disease, maybe even a tumor. But when you see the chest X-ray and see the fine reticular pattern throughout the lung fields and see that it must be miliary TB, then there's nothing much else it could be. This is also the CT scan and plain X-ray of a child who's got CNS TB. And I wanted to show you this because even when we don't have CT scans, if you don't have a CT scan, but a child presents with CNS symptoms, then you can do a chest X-ray and you can see this feature on the chest X-ray, which is called copper beating. All right, and you can, if you look at the skull X-ray, you can see that there looks like that it's like a copper bowl that's been beaten out with a small hammer, and that's what's called copper beating of the skull. And that this was this boy's skull X-ray, and you can see from his CT scan that he had hydrocephalus. His ventricles, these are the lateral ventricles. All the lateral ventricles, they're markedly dilated, and it's because he's got a large lesion in the posterior fossa, which was TB. It could also be a tumor, but it was TB. I won't talk too much about MDR TB today because what I wanted to do is try to cover the diagnosis of TB, but I think we need to be clear about which patients we should test for MDR TB. And the most important thing is to know that we test patients for MDR TB. It's usually a bacteriological diagnosis. That is, unlike the diagnosis of drug-sensitive TB, which we can make on history and examination and basic tests. For multi-drug resistant TB, it's usually a bacteriological diagnosis, unless the patient has a direct contact with someone that you know to have MDR TB. So we should do tests for MDR TB on any child who's got TB that's failing to respond to first-line drug-sensitive therapy in the intensive phase. For any child who's had exposure to a known case of MDR TB, we should do it for any child who's got HIV and TB because they're likely to have MDR TB, etc. So the most important thing is to know when to test for MDR TB. I'm not going to talk more about the diagnosis of or treatment of MDR TB today, but I really wanted to just cover off how we diagnose TB based on history, examination, on the clinical features, on special tests, looking at different organs of the body and different tests in different organs, like a specific test for mycobacterium tuberculosis and immunological tests, and how we can integrate them all. So I hope that's been useful. I think most of it you knew, I believe, but it's really a matter of putting it all together and being able to decide in this patient, what tests do we need to do. So that's all. I'm going to stop there and happy to answer any questions.